Good afternoon, everyone. I'm Michal Meiri. I'm the co-founder and CEO of Agamon Health. Every oncology practice wastes time and revenue to the work that happens between visits. Over the next few minutes, I'll show you how leading oncology practices are already solving this today, with AI agents that work around the clock. Let's start with a problem every practice in this room knows too well: chart prep. For MAs, it's hours of manual, repetitive work leading to burnout. For physicians, it's walking into the visits without the information they need. For patients, it's delayed treatments. And for the practice, it's late cancellations, missed revenue, and empty chairs. It's a process problem, and it's exactly the kind of problem that AI can help you solve. Here's the part worth paying attention to. Chart prep has always been chronological. Your MA works the schedule patient by patient, hoping to catch what's missing before the next visit. Two things have changed. One, LLM can now read unstructured notes, similar to the way a person does, pulling care plans out of free text. And AI agents can handle multiple steps across systems, full workflows that branch, wait, retry, and escalate. Agents are working continuously in the background, escalating only the cases that require human intervention. The chart prep work is no longer scheduled. It's always on. And so let me show you what that looks like. The AI reads every note, office visit, pathology, outside records, and identifies what's due before the next visit. It surfaces everything on a widget embedded directly in your EMR, whichever one you use. No new login, no new screen. For each patient, a quick snapshot of orders due, results matched, and anything missing is flagged and communicated to the physician within the EMR system. In this case that you'll just see, the patient has external results that are due. The agent has already drafted the message to the outside facility, so the MA can just review and send it automatically. When results come back, the system aggregates into a single view so that the physician can walk into the visit fully prepared, knowing what's there and what's missing. The work still gets done, but your team just doesn't have to do all of it. Under the hood, we have specialized AI agents that continuously extract care plans, gather what's missing, and close the loop across systems. The result is simple. Nothing falls through the cracks, and the physician walks into the room fully prepared. The MA moves from gathering information to validating it, faster, more accurate, and far less exhausting. One practice we've been learning alongside is Oklahoma Cancer Specialist, where the initial results show 34% reduction in chart prep time and 30% reduction in late cancellations. A few things that I'd like to share from what we've learned. First, the product has to adapt to the practice. Oklahoma wanted patients flagged when insurance was likely to delay authorization. Specific payers, specific drug categories, surface days ahead. So we built it and customized into the product. That's the pattern across every deployment that we have. The agents do the heavy lifting, but the playbook comes from the practice. Second, we measured value from day one and kept a tight feedback loop with MAs, physicians, and leadership, adjusting as we went. And the benefits apply to different types of practices. For a small practice, MA saves 1 to 2 hours per day, late cancellations drop, and it pays for itself quickly without adding a single FTE. For a large practice, you get standardized workflows, lower burnout, and you protect downstream revenue that's currently leaking through missed authorizations. We connect to your EMR, configure it to your practice rules, go live on a small scope, and then optimize. We start with the MA on purpose. It minimizes clinical resistance, and the value shows up quickly, without asking physicians to change a thing. Prove it, then expand. And chart prep is just the entry point. The same foundation extends to other operational workflows. But the real shift isn't a single use case. It's the operational work that continuously runs in the background, freeing your team to make the clinical judgment only people can provide. This is the kind of problem we believe community oncology is uniquely positioned to solve, close to patients, fast to move. A few years from now, doing this type of work manually will feel as outdated as paper charts.